Thank you for joining us today. It's a pleasure to welcome you all here today. My name is Wendy Heinzelman. I'm the Dean of the Hagem School and also a professor in electrical and computer engineering and also in computer science. And I'm really looking forward to today's presentation on embracing digital innovation in healthcare, which is a very timely and important topic. We have a wide range of registrants joining us for this session that include alumni, parents, students, faculty, staff, and even a number of prospective students. I welcome you all and hope that you all learn something new and interesting in today's presentation that's going to discuss a number of innovations being developed at the University of Rochester Health Lab. So the University of Rochester Health Lab is the medical center's digital innovation incubator, which brings together faculty and students from across the university to leverage technology to solve some of the most pressing problems facing patients and clinicians. The lab integrates machine learning, virtual reality, 3D imaging, wearable sensors, all to drive precision medicine. So today we are going to hear about the lab's initiatives and partnerships and how digital innovation is used to revolutionize healthcare and how to bridge gaps in healthcare by fostering collaboration. Before I introduce today's speakers, I would like to offer my deep appreciation to Bob Huang, who had the foresight to make today's program possible. Bob is a University of Rochester alumnus who made a significant investment in the University of Rochester in support of programming in technology and innovation. Today is the fourth virtual event for the Huang Speaker Series in technology and innovation. Thank you, Bob, for your support of the university. And now I'd like to introduce our speakers for today. First, we have Michael Hasselberg, who is an associate professor of psychiatry, clinical nursing, and data science at the University of Rochester. He is also the first chief digital health officer at the University of Rochester Medicine and is co-director of the UR Health Lab. Joining Michael is Dave Mitten, a professor of orthopedics and biomedical engineering and fellow co-director of the UR Health Lab. And I am proud to note he is also a Hagem alum, having received his undergraduate degree in chemical engineering from the University of Rochester. So thank you both, and I'll now turn it over to our speakers.
Thank you, Dean Heinzelman. It's an honor to be here, be part of the speaker series. Michael and I are really excited. I think the topic of today is really about, how do you embrace digital innovation in healthcare? And it's a team sport, and it's not quite as easy as it may initially seem. First of all, we believe that healthcare should be better. We believe that no one should be left behind, that we need to bring everybody along as we improve our healthcare. And we also need to focus in on the whole patient, and as well as providers. Providers are important as well, and we're at record levels of burnouts within our providers. And so we really need to be focusing on the whole picture. In the health lab, we work on projects to improve both providers as well as patients. And the key twist is we really believe that technology is going to help us get there in the future. And so this first slide is something that I call it the only Rochester slide. And this is a slide on the left is Gregory Hayworth, who's a digital humanities professor, who I watched give a talk about using optics techniques to revive the text out of ancient scrolls. And I'd always thought in the operating room, it'd be great if we had digital techniques to help us see tissues better. And then we partnered with Wayne Knox, pictured on the right. And Wayne is a professor of optics, and he brought one of his students in with us, Howland, in the middle. And between the three of us, we developed a new technique for imaging nerves for laparoscopic surgery using cross-linear polarized light. And it's something where you have a humanities, optics, and then orthopedics coming together. In the middle slide, this is a neuroscience student working with a physician assistant, with a plastic surgery resident, and Howland, a PhD student in optics, in a new $240 million orthopedic research and clinical care building. And it shows the opportunities that these students get involved with, and how we do new technologies, develop new patents, and develop new techniques. Michael, just stay on this slide for one more second. When we talk about innovation, it's really not about innovation alone. Innovation alone isn't enough. We really think of three things in the health lab. We think about, number one, creativity, and that's asking better questions. We have to learn how to ask more insightful questions to really get at the root of the problem. We need innovation, and innovation is applying new technologies, like I showed you here with, using cross-linear polarized light. And then there's execution, and execution is something that's often underestimated. It's really hard in healthcare. How do you develop these solutions? How do you scale them? How do you train individuals to use them? And then really now in the age of AI, how do we ensure the safety and efficacy? Are these new solutions doing what we thought they would? Are they leaving certain populations behind or not? And you'll see as I go through our structure how we've come to address that. I think what we have realized is that you need a robust infrastructure around innovation, and you need great people. And both of these things just don't come out of thin air. They take a lot of work. And I'm going to highlight sort of how we organize our approach to this, and how do we get great people involved. And finally, we're going to really understand that there is a major new escalation of AI in healthcare, and it's going to play a major role. And Michael will highlight some of that as we go forward. Michael, go to the next slide. So the Health Lab is this really broad organization. We have over 30 faculty from around the university, from engineering, optics, Warner School, physicians, nurses, doctor of nursing practice, really from every part of the university. We've partnered with 10 startups. We really think that these innovations have to be something that we can use, and then we should partner on the upside as we scale this across the country. We have over 15 IRBs, and what those are research protocols on people. We have over 15 projects where we're taking these innovations and using them to improve the care of our patients. We have 6 active grants. We have 13 learners in the lab. We have undergraduates, we have residents, we have faculty members, and a diverse group. Next slide, please. We also really need a great location. We're located here in Corporate Woods, where I'm sitting right now. This is at the ground floor of the technical infrastructure of the medical center. Right above me is the chief information officer, as well as the chief medical information officer. And we work very closely with them as we try to integrate these solutions into the population and into our workflows. I think as you go to the next slide, Michael, how do you do this architecture? How do you, in a large academic medical center, start to do this? And we split it right down the middle. We have 2 cores that are managed by the medical center and 2 cores managed by the River campus, or run by those 2. It really speaks to the how we have synergized working together. And the 4 cores are data analytics, and data analytics is essentially fundamental. I won't be covering this very much, and Michael will be going into this in a little bit more detail. Education, we like to say education is the flywheel of innovation. You don't have innovation without students. And, as we start to look about education, not only do we have to train our patients and our providers, we also have to train each other in innovation. Machine learning, if you're not doing machine learning at this point, you're left behind. And then software is going to develop. How do you develop those digital tools that allow you to use these products in the healthcare system? Next slide. And then, data analytics is run by Dr. Kathleen Fear, who's, an amazing addition to our program. She runs a team that is majority female, and we're really proud of that. We really look to include everybody in innovation and in technology. It has to be, representing our diverse populations. We're really proud of Kathleen. She won Emerging Technology Woman of the Year in 2021 from Tech Rochester. She's published in the New England Journal of Medicine Catalyst, and she has played a key role within the university and runs a team of over 5 data scientists that apply their skills to all of our projects, as well as the operations of the medical center. Next slide. Wendy Cross is a PhD that runs our education program. And really, our education program does 2 things. It's also our research arm. She runs all of our research projects, all of those IRBs, or those research protocols run through her lab, through her division. And then she manages all the students that work with us. As I mentioned, we have over 13 students working with us. We've had data science students, and we've even hired some of these students. So students have come and worked with us and have made a career here in the Health Lab, and we're really proud of that. I think when you think about what we're doing here, it's about education, and there's 4 major educational formal programs we have. One is ethics in AI. And as I mentioned, we are really worried about what AI means to our healthcare, and we're really worried about potential of unintended consequences in the data. And we're realizing the data may not represent our underserved populations as well as they should. And so we have a program, Reverend Kevin Boyd is heading up, where we're looking and teaching us about these ethical issues and even putting together a consult service. So as folks within the university are developing solutions that involve technology, Kevin can help us work through where unintended consequences may occur. Just recently, we were approved for a Master's of Science program in combination with the Center of the Gergen Institute for Digital Sciences. And this is a new master's program approved through New York State that the Health Lab as well as GIDS will be performing together. We're super excited about that. Heather Reyes is a pediatric intensivist, and Heather runs a digital innovation track through the Health Lab, mainly designed at residents and nurses. Residents and nurses go through her program. This was funded by Dean's Teaching Award and has been very well received. And really, we view ourselves as training the next generation of technically and digitally enabled physicians. And finally, preventive medicine at the university. Their residents spend time with us in the lab as part of their residency. Next slide, Michael. Software, Cristiano Taparella, who Dean Heinzelman, I stole him from her. She was in his lab. And one of the things we do around here is we steal the best from anybody who will give them up, whether they like it or not. So sorry, Wendy, about that. Cristiano's done an incredible job. And on the left here, he headed up the Rock COVID project from a technical design. Rock COVID was a chatbot we had out in the community through a partnership of Adam Bello, the city, Rochester Regional, our rival healthcare system, Common Ground Health, and even Verizon. Verizon donated the texting services so everybody could text without using their plan. And that at its peak had over 70,000 individuals from around our community using that chatbot. And that information informed us in the early days of COVID of where to apply PCR testing when we weren't sure where the outbreaks were occurring, and is an example of execution at a large scale. The next video in the middle is Cristiano's team is really into VR and have developed many VR tools ranging from brain training games with a team at Stanford to help with patients with Alzheimer's to this example in pediatrics. And this family has given us permission to use this video where we're using VR in the hospital setting to try to lighten the load on difficult patients that have a hard time in the hospital setting. You'll see here a patient with a trisomy 21 who is really anxious about getting treatments. And you'll see that his mother gives a description of what it's like in Cristiano's VR environment. Go ahead and hit play, Michael.
Even though he is wiggling around a lot, he is still very interested in what is going on in the video. And he's not hitting, he's not, as you see, he's tapping it, but usually he'd be trying to bite and smack everyone else. Are we all done? Or do you want more? Do you want more? Okay, put it back on.
Thank you.
And it's very easy for him, usually with his grasping, it's hard to use anything.
Mm-hmm.
So with the cushion, it's very textural, easy on his face.
Huh.
And like I said,
That's
he
a great
usually
point.
is trying to go after whoever is trying to do any sort of procedure on him.
Yeah.
So he's more into this than what's going on with his body.
It's very interesting. Thank you.
You're welcome.
So, this is exciting for us. If you're a software developer, you want to make an impact in this world. And, you can imagine the team that writes this software, that they get to see this in a patient's room actually being used. It's really a great way for us to recruit incredible people and the right kind of people that want to make an impact. And finally, the software team has developed a cognitive behavioral therapy app. And this is done to be delivered through a mobile device. And we're super excited about that, probably rolling that out later in the year. And then we'll talk about the machine learning and AI. Ajay Anand from the River Campus runs this. He's also the deputy director at GIDS. And Ajay has won the teaching awards on the River Campus in the past. He's an incredible part of the team. And here you see what we're doing. We're partnering with a company called Butterfly, and I have a Butterfly here in my hand. It's a handheld ultrasound device that uses a chip to deliver ultrasound. It's the first in the world to do that. That company works very closely with us and our team, and Ajay and several data science students are developing new techniques in ultrasound to use machine learning to label those tissues and make new diagnoses. These are alive now in my clinic. Right now, when I diagnose carpal tunnel syndrome, I use this ultrasound, and I avoid using what are called nerve conduction studies, which are painful, expensive tests. So when a patient comes to my office as a result of these tools that Ajay is developing, I can immediately diagnose the disease process and treat them immediately. Real change. In addition, on the right, we have a problem with bone injuries and getting those bone injuries to heal. Using the same device that helps us diagnose diseases, we're using it to treat. And the slides here show some early studies where using basically a computer chip to deliver energy to the bone has enhanced healing. These are great projects, real world projects on the bleeding edge of science, but are being used clinically here at the university, a result of the health labs team. Next slide. And then, finally, I'll introduce Michael Hasselberg. Michael is going to be speaking to you next. Michael is a nurse practitioner, PhD. He's a national leader in healthcare innovation. He's an incredible leader here at the university. And what I didn't mention, when Cristiano in the software team developed Rock COVID, we open sourced it, we gave it away. And as a result of that, the X Prize was pretty impressed that we were doing that. And Michael has become part of their brain trust. And you see here, Mike sitting next to national leaders in healthcare from large pharmaceutical companies, and plays an incredible role as an innovation lab. Without people like Michael to get these ideas out, and we call outside in, bringing the best ideas to us, we'd really have a problem succeeding. So with that, thank you for your attention, and I'll turn it to Michael.
Thank you, Dave. And, this is really exciting for us to be able to talk about our work in the health lab. And as Dave said, that the health lab is one of the few places at our university that the university really overlaps with the health system. And, we truly believe in that mission of being one university and taking the knowledge capacity across our entire organization to support one of our big missions, and that is delivering healthcare. One of the really kind of key purposes of the health lab is to support the digital transformation strategy of the health system, where we're really trying to redefine care at the University of Rochester Medical Center, where we move from kind of the traditional way that care is delivered to being a digital first health system. And what I'm going to walk you through on this slide is really what our digital transformation strategy looks like at the health system. When we thought about our digital transformation strategy, we really broke it up into 3 buckets, with the first bucket being focused in on access. And this was this concept of how do we leverage the technology that our patients already have, their cell phones, their tablets, their computers, and really create that seamless, convenient experience to enter into our healthcare system. The second part of our strategy was really focused in on engagement. And this was this idea of you've leveraged technology to help patients enter into the healthcare ecosystem. How do you keep them engaged with our health system, but how do you also keep them engaged with health prevention and in healthy living and well-being? The really kind of secret sauce to our transformation strategy is the data behind our digital front door and our virtual care platform. We are now collecting new types of data on our patients that we've not otherwise had in the past. And that data is what's going to lead us to the end of our digital transformation strategy, which we call value, or a smart health system. This is really where we start to transform healthcare to make it more personalized and precision-based, allow us to deliver the right care at the right time, at the right place, by the right provider, and really leveraging data and machine learning and data science to get us there. So when we think about our technology stack as a health system that supports this digital transformation strategy, we start with our foundation. And our foundation is our electronic health record. And at the University of Rochester, our electronic health record is called Epic. And when we think about, turning on new functionality and technology, we always look to see what can our electronic health record do for us right now, or what is on their roadmap. But unfortunately, the electronic health record has a very wobbly foundation. There are a lot of gaps. And that's where we look to, partner with industry, where we first look to buy the best of breed technologies out there to fill in those gaps. But if we can't find the best of breed partner out there, we also look at partnering with startup companies. And that's really where the health lab comes in. We serve its two roles as a health lab. We build technologies, which Dave introduced, but we also partner with a lot of industry partners to co-develop technologies and almost serve as a venture studio where it's our innovation team that puts our arms around these technologies, arms around these companies. It's our clinicians in our labs that start thinking about how do we integrate these technologies into clinical workflows. It's our software team that's really thinking about how do we integrate these technologies into that electronic health record. It's our data team that's, really thinking about, how do we measure the value of these technologies. But the last is built. There are often times where we can't find an industry partner that has the solution to solve the problem that we're trying to solve in the health system. And that's where we really take that diversity of thought, use a design thinking process, and we'll build the products from scratch. And as Dave mentioned, we build everything from mobile apps to chatbots to VR and AR applications to sensors. We have engineers soldering in our innovation lab, and really all machine learning that touches our clinical service lines in the health system. There's a high likelihood that the innovation team in the health lab had a finger on that technology. We're also, we love to think about open sourcing our technology. If we find a technology that works for our health system that we think would benefit from others, we've got several examples of, both our, some of the chatbot technology that Dave talked about, to even some of our VR technologies that we will just open source the code and we will share it with others around the country to leverage these tools. And that's done a lot of great things for our health system, and university. It's really increased our reputation, and it's increased our partners, both, within industry, but other health systems, other universities, and even the federal government around some of the innovation we're leading. So when I talked about our digital front door and access, really where we started was we partnered with a startup company to really launch a chatbot. And this chatbot we put up on our websites, and this chatbot interacted with patients around how do I sign up for the patient portal? How do I pay my bills? How do I find the right provider within the University of Rochester? And we really partnered closely with this startup company to help us clean up our data, because the way that patients were searching for our providers in our health system, the terms that they were using was not how we labeled our providers within the system. And this really allowed us to clean up our data so we could really then turn on online scheduling. So, you could have that almost like open table experience when you're trying to get a reservation at a restaurant. You could do that within our health system. You could see what providers were accepting new patients or had open appointment slots, what day of the week those slots were available. And with a click of a button, you can schedule your appointment with our providers and no longer have to go through those call centers where you're stuck on the phone for hours trying to get an appointment. And so several of our providers across our health system, we have turned on this online scheduling. We then really shifted our gears to focusing in on how do we make that check-in process easier? How do we get rid of all of those forms that you have to fill out, all those questionnaires, insurance information, demographic information, and how can we turn on that functionality so you could fill out all of those forms on your own device, your phone, your computer, your tablet in your home before you ever arrive to that appointment. And so we, really turned on this e-check-in functionality. And for clinics where we knew that we had a lot of patients that didn't have those mobile devices accessible, we put up kiosks in those clinics, almost like when you go to the airport to check in on a kiosk. If you don't have the mobile check-in, in some of our clinics, we have these kiosks that you can just check in instead of needing to go to the reception desk. We then pivoted back to telemedicine. And when I say pivoted back, we've been doing telemedicine at the University of Rochester for, years, 10 plus years prior to the pandemic. But the one thing that we did not have was really an on-demand telemedicine platform where, I have this urgent care need. I want to see a provider right now. I want to see who's available. And with the click of a button, be in that appointment with that provider. And we partnered with another startup company and we really integrated this on-demand video service platforms, which is staffed by University of Rochester primary care providers, pediatricians, and soon behavioral health providers that can see anyone in New York State almost 24/7 at this point. And really the wait time to be seen is around 7 minutes for those urgent care needs. And then the end of our kind of digital front door, that access piece, was really creating that Apple Pay experience with, you can see how much your appointment costs, and with a click of a button, you could pay your bill. We've then kind of moved on to the engagement part of our strategy, which we would know is going to require lots of different technologies to kind of keep patients engaged in our health system and engaged in prevention. And so again, the health lab, we partnered with another startup company to kind of create a power strip that plugs right into our electronic health record. And into this power strip, we're plugging in lots of different technology modalities that we can prescribe out of the electronic health record, and then the data that's collected on those technologies flow right back into the patient's record. And so, different technologies are, SMS, texting-based digital care pathways, and again, sending out questionnaires. Some of this we've built within the innovation team. Some of this we've partnered with, again, external companies, taking patient education from handing out paper handouts to giving that more of that YouTube experience and making, our education materials accessible via videos. And the ability to prescribe mobile apps. And as Dave touched upon, our software team built a cognitive behavioral therapy mobile app that we will soon be giving access to our primary care providers, that they can prescribe it right out of the electronic health record for patients that they have concerns around anxiety or depression symptoms, and we're unable to get them in to see one of our psychiatric providers soon enough. Things like the ability to address social determinants of health. The University of Rochester serves a very large geography, and we have a lot of rural communities where transportation is an issue. And so the ability to prescribe out of the electronic record, common ride share applications like Uber or Lyft. And then finally, as Dave described, the ability to prescribe virtual reality applications. And we've got VR headsets across the hospital. We've got them in our adult medical units for providers or patients need a procedure. We've got them in our children's hospital. We've got them in the dental institute where patients could be in a VR experience while they're receiving dental care. Soon, we're going to be rolling out our VR applications across our residents that are getting training within our health system to helped teach them their own personal mindfulness and meditation to potentially reduce clinician burnout within our health system. So, Dave touched upon, data analytics support for the health system. And one of the, things that our data team under Dr. Kathleen Fear does is does some of the more strategic high level data analytics and dashboards for our executive team to make some of our big strategic decisions. And what you see here is some of our telemedicine data. And the reason this came down to us within the health lab to do this analysis was, when the COVID pandemic hit, our health system, like every health system in the country, essentially had to ramp up telemedicine overnight, where we went from about 4% of all of our ambulatory care pre-COVID being done via telemedicine up to like 80% of our ambulatory care being done via telemedicine within a few weeks. And as the pandemic rolled on, there were discussions that when the public health emergency was going to end, that reimbursement for telemedicine, at the same rates as in-person care would go away. And so the health system asked our team to do a deep analysis around, was telemedicine benefiting, our patients? And what we found was absolutely. And where we were having our biggest benefits was with our Medicaid patients. And it was our patients living in our inner city and rural communities that benefited the most from telemedicine, actually had improved no-show rates and cancellation rates, didn't end up in the emergency department more frequently than Medicaid patients who were coming in person, and actually required less follow-up in-person care, lower high-cost imaging and lab tests for the Medicaid patients that received care via telemedicine than those in person. And that was a hallmark paper that we published in one of the most impactful academic journals, the New England Medicine or the New England Journal of Medicine Catalyst. And that paper that came out of the health lab is one of the hallmark papers that's used in this country to make arguments to payers that you should continue paying telemedicine at parity because it really helps some of our most underserved patients. There was a caveat, however, that we found to the data in this paper, that in our rural communities, our patients were only engaging in audio only and not engaging in video. And initially we thought that this was a broadband issue in our state, that there was no broadband access out into these rural communities, but we were wrong. We actually have a really strong broadband infrastructure in the state of New York, but it was a poverty issue. And the only internet access that our patients in our rural communities had was their data plans on their cell phones. And data video is a very data intensive feed, and our patients did not want to use their data plans up for video. So that got us really thinking about how do we meet our community needs in these areas. If telemedicine audio only reimbursement was going to go away, how could we still provide care to these patients? And so our data team essentially geocoded every address of all of our patients at our health system. What you see as on those dots on this map is one of our patients, their address is coded. What you also see is the primary care practices, brick and mortar practices, part of our health system. And outside of the city of limits of Rochester, up here at the top of the map, we found that, almost 70 to 75% of our patients outside of those city limits live 10 miles or more from the closest primary care practice. And then when we geocoded our urgent care clinics, it didn't get any better. It was around the same, 5 to 10 miles away to the closest urgent care practice. And so we really needed to start thinking about who were other types of partners that we could, possibly set up telemedicine hubs out in our community to continue reaching these patients. And something really potentially transformative happened in 2021, right, kind of in the middle of the COVID pandemic. Dollar General came out and announced that they were going to get into healthcare, and they hired a chief medical officer. And so, me in my role of chief digital health officer, I was said to myself, wow, this is potentially could be really transformative for healthcare. And so I asked our data team to geocode the Dollar Generals in our market. And what we ended up finding out was that, over 80, almost 85% of our patients outside of the city limits lived within 3 miles of a Dollar General store. And so I immediately got on the phone with the new chief medical officer at Dollar General, essentially within the first week that he was on the job, really pitching to him, you should partner with the University of Rochester so we can increase access to healthcare services, via telemedicine. And to give Dollar General credit, that they were not ready at the time that we reached out. They were still figuring out their strategy, and they decided to not partner with us and go in a different direction. And now they're in Tennessee, delivering healthcare at Dollar General stores in vans out in the parking lots of those stores. But we were kind of back to the drawing board of, who else could we partner with? And we really started thinking about what are in these rural communities. And a lot of these rural communities, you have a main street, a traffic light, a dollar store, and you have a bank. And we thought, what about banks? What if you delivered healthcare into a bank? That may be a good location. And so we looked at, what banks were in our market, and we found out that a community publicly traded community bank called Five Star Bank had the most market share. And we reached out to the CEO and president of Five Star, and we kind of discuss, hey, what about a partnership where we could deliver healthcare into banks? And Five Star was extremely excited. They said, this meets our mission of giving back to the community. We've got all of these brick and mortar banks within this branch distribution model, which has real estate that it's not being used because the banking industry has gone through their own digital transformation. And so, we could absolutely provide you that space. And that led to a whole new partnership where we partnered with Five Star Bank. We got funding from several health foundation philanthropy organizations like the New York Health Foundation, the Greater Rochester Health Foundation, the Schmidt Futures Foundation. And we partnered with the likes of Verizon to bring connectivity into these bank sites. We partnered with our on-demand telemedicine software startup company DexCare, and we partnered with this company called Higgy Health, which had these biometric stations that if you go into a pharmacy or a grocery store or gym, you may see a Higgy Health station, which you could get your blood pressure and vital signs taken at. With the partnership with DexCare, Verizon, and our innovation team, we really took those health stations to the next level, and we integrated telemedicine into those health stations. And now we have these health stations in Five Star banks in our community. And this has really got a lot of national kudos, where we've got, just this past week, several leading national healthcare magazines and journals have reached out to us to highlight our work and applaud us for thinking outside of the box and coming up with, all these partners to do this really an innovative approach to not only potentially improving healthcare access to our rural communities, but also maybe addressing financial well-being and keeping those communities financially well. So now let's talk briefly about, data science and kind of the machine learning and AI and the future of healthcare. And, we've been talking a lot about AI over the last year because of ChatGPT-4, but AI has been around for quite some time, and it's been around in healthcare for some time. And, really where we started talking about in healthcare was, back, in 2011 when IBM, a company, just south of us from Binghamton, New York, launched Watson, and Watson went on to win on Jeopardy. And after Watson won on Jeopardy, IBM, had this audacious goal where they were going to transform healthcare using artificial intelligence. And they partnered for some of the leading cancer health systems across the country, Cleveland Clinic, MD Anderson, and they wanted to show that AI could potentially cure cancer, find new treatments for cancer, personalize cancer care. What ended up happening, however, with IBM, just within the last 5 years, Watson Health was unable to deliver on, what they were excited about potentially transforming. And IBM actually spent about $4 billion buying healthcare data to test the AI technology on. And despite that $4 billion investment, they ended up selling IBM Watson Health to a private equity firm for pennies on the dollar. And so, why did IBM fail? And partly it was because, the data that we have within healthcare and within our electronic health records has a lot of noise in it, a lot of variability in it, and we're not really sure if it's the right data that we need to perform machine learning. And it was actually an orthopedic surgeon, Dave Mitten, who at the U of R said, maybe we're collecting the wrong data. Maybe we should really just ask the patient how they're feeling. And so we started collecting data differently at the U of R, probably about, around the time of 2011, when kind of Watson Health started launching. We decided to embrace our roots of being a biopsychosocial health system. And we decided that we were going to use simple technology built by the Innovation Lab, where we were going to collect your psychometric questionnaires about your physical health, your psychological health, and your social health at every single touch point when you came into our health system on an iPad. And then we integrated that right into our electronic health record. And now today we have the largest patient-reported outcome data set in the entire country. And that's what we use as the foundation to a lot of our machine learning models. And we've been able to successfully build machine learning models to predict patients' need of going into a skilled nursing facility after surgery, all the way to building predictive models to predict mortality rates, and have integrated some of these models right into our electronic health record. But where we're focusing today now is on our clinicians. Given some of all of the success that we've created using technology to better serve our patients and create easier access and engagement of our patients with our health system, it's in some ways had a detriment on our clinicians, where it's never been easier for our patients to get that easy access of our clinicians. And what you see on this graph here is the day in the life of a University of Rochester primary care provider and how they spend it in the electronic health record. What you see on the bottom graph is their scheduled patients. And what you see on the top graph is our providers are waking up early in the morning. They're opening up the electronic health record. They're prepping for their patients for the day. When they get started around 8 a.m., they're in that electronic health record, working, typing, documenting. We see a little bit of a dip around lunchtime. It starts to slow down going into the 6 p.m. hour. Our providers go home. They have dinner. Starting at 8 p.m., they're back in the electronic health record, answering patient messages, ordering refill medications, and finishing up their documentation until they go to bed at night. And this is not an outlier. This is what an average day of a primary care doc looks like. And patient messages over the last several years have gone up 230% within our health system of patient messages going to our providers. This is where we're excited about the potential of generative AI and these large language models. These foundational models that we've had early access to them for over a year now in a secured instance on our cloud instance through Microsoft Azure. And we've been putting patient information into ChatGPT-4 and other large language models in a secure, private manner. And we're blown away with this technology. We've already, in the innovation team, built tools that the AI will triage those messages appropriately. Say, this message shouldn't go to a provider. This should go to a nurse, or this message should go to a staff member. We've built tools using generative AI to summarize patient charts concisely, and even pull out the information right up to the forefront for our providers as they're prepping for their day, to really show the information that our providers need to see for that visit, all the way to the ability for our providers to chat with data, to really kind of interact with our enterprise data warehouse and directly ask questions that they need answers to, and not have to wait months to get a report back. Other areas that we're moving into, both partnering with startup companies and big tech, is around ambient documentation. The ability where, if you're in a patient encounter, you put a cell phone between you and the patient in a secured manner. It's listening almost like your Alexa is, or your Google Home is, or your Siri is. It's listening to that conversation and only taking the pertinent information from that conversation that's needed for that clinical note, and doing that documentation fully for our providers, so they don't actually have to be sitting in front of a computer screen the entire time documenting. And I'll play a kind of a version of what this looks like.
So tell me what's going on with your shoulder.
I had this accident skiing, and now, my shoulder's just super painful, and I can't sleep at night. I'm up all night because of the pain.
Which shoulder is it?
My right shoulder.
Your right shoulder. How long has it been going on?
So the ski accident was like a week ago. So yeah, about a week.
And what have you been doing so far to try to make it better?
I've been putting ice on it. I've been taking some Advil.
And with that, that is how the University of Rochester Health System and the Health Lab is trying to transform healthcare for the better, and really, again, leading innovation in a multidisciplinary way. With that, I'm going to turn it back to you, Wendy, for the question and answer portion.
Yeah, thank you so much. This was absolutely fascinating, and we have a lot of questions coming in, so I'm going to get right to a couple of questions. The first one is, there's so many technologies that you've developed and so many new ways of thinking about healthcare. I mean, I'm just amazed at the statistic you gave about 7 minutes as the average wait for someone to see a telemedicine clinician for something that's gone wrong, and what a game changer that would be. How many people are currently able to use these sorts of systems? So just as an example, your online scheduling, your telemedicine, the systems that are in the banks, how many people can actually use that at the current time? And how do you scale these so that people across the country can actually access these types of technologies?
Yeah, so the examples that you described are available to any patient. So any U of R patient, or any patient living in New York State. So they can take advantage of the online scheduling. The issue that we have of trying to schedule appointment with some of our providers in our brick and mortar practices, we have long wait times for certain specialties. Some providers are not accepting new patients, so that can limit that can limit the potential for online scheduling. That's why we're trying to increase our workforce by taking burden off. But our on-demand telemedicine service that we offer primary care and pediatric services for urgent care issues, it's open to anyone. And and those that don't have devices or can't afford internet in their home, we have 3 pilot sites at the banks in 3 rural communities. But again, it's open to anybody in those communities can come and get our on-demand telemedicine care at those stations. And you know, like you said, and as I said, our wait time for that typically hovers around 7 minutes to see a U of R medicine provider, not some national provider through Amazon or you know some of the disruptors. This is a local healthcare provider from our health system.
Yeah, that's absolutely amazing. And, I know there's a bunch of questions. Are you going to expand beyond New York State? Is this something that other healthcare systems are trying to come to you to understand how you do things here so that they may be able to replicate?
Yes, yeah. So the bake idea that again, we just went live with the bake idea. We've already had health systems from Nebraska and Indiana reach out to us, say this is brilliant. You know, we want to partner with our banks to do this. And then, you know, the one of the kind of exciting things about our on-demand telemedicine platform, you know, and our partnership with DexCare, which spun out of Providence, which is a health system. It's spun out their innovation team out of Seattle, Washington. It's a on-demand telemedicine platform for health systems, you know, and that's who uses it. And we're already in discussions of how we can come together as health systems across the country around doing capacity overflow using that platform across state lines. So more excitement to come as we explore that with our colleagues at DexCare and Providence Health.
Fantastic. And, along those lines, there's so many ways you've talked about helping those in our community. How can students get involved? How can students either work with the health lab, work in the health lab, or use partnerships with folks like Higgy that you talked about to generate innovative projects that can also help in the community?
Wendy, I'll jump on that. I think, we have a whole education core. We have a team to intake students. We meet with students all the time. They express what they're interested in. A lot of students will just come and sort of attend our meetings and start to learn what we're up to before they jump into a project. But we have a whole intake process. We have limited resources, so we take the best students. We can't take everybody, unfortunately, but really motivated students with really interesting perspective. I'll give you a quick example. We have a master's student from Eastman who just came from New England Conservatory working on health of musicians. And we're using AI and incredible tools, what we've seen here, using those for our musicians in Eastman. So, there's people coming from all different areas. We'll take anyone. We have a saying, anyone, anywhere, anytime. And, whoever's motivated, and we'll meet with our team, we're happy to discuss opportunities.
Fantastic. And a question came in about accessibility. So a lot of these, how accessible are these types of technologies to those who have limited vision or hearing or other sorts of impairments? And have you thought about accessibility sort of baked into some of your technologies?
Oh, 100%. And so, part of, our really close integration with the health system is we have various different patient councils that, represent underserved patient populations. And, we will partner with those patient councils, especially if we're developing a new technology, to make sure, we are thinking about accessibility and equitable deployment of that technology and aren't missing something. And then, when we partner with industry partners, we have an ethics team embedded in-house. We're really, again, thinking about, ethics and equitable access and make sure that we are inclusive as possible. And again, part of our kind of mission in the health lab is to really serve gaps in our communities, and partly that's why we've also taken the open source approach with a lot of our projects. Is if we think it's helpful for our community, instead of trying to figure out how do you sell this or license this, it's no, let's give it away to other systems that maybe don't have a health lab and aren't able to build this stuff, so we can get this out there to help even more individuals.
Yeah, fantastic. moving along to a different set of questions, you talk a lot about AI, and you've gathered amazing data, and data that many other places don't have. So you can actually utilize that data, and you're doing things that are very unique and innovative. How do you get both doctors and patients to trust AI? And then along those same lines, how do you also think about security and confidentiality? Because AI systems are built on individualized data. So how do you protect patient confidentiality as well?
I think Michael is working, I think, with a national group around this. So I'll let Michael jump on this.
Yeah, I mean, there's so much. AI is moving so fast, faster than it's ever moved before. And, there's not going to be one single institution that's going to be able to really solve the safety and trust portion of AI. And, in the worlds that I live in the chief digital officer world, chief innovation officer world of health systems, this is our hot topic. And what's really great about academic health systems is we've had several forums of academic health systems where we come together, in senior leadership discussions, closed doors discussions about how we can partner together, leverage different platforms that each of us are using to validate models, to monitor and audit models after they're deployed. And so that, those conversations are absolutely happening at a high level, and in partnership with the federal government, where there's been an executive order pushed out by the Biden administration around safe and responsible AI, in partnership with the FDA and our Office of the National Coordinator, also meeting with these health systems. Now, within the health system now, in our current AI models, the innovation team, we work very, very closely with our IT department. And as Dave said, right above us is the chief technology information officer, our chief information security officer, is in this building, and they're the experts. And we work very closely with them. We're lockstep to make sure that we're meeting all of the security measures and protocols that are required in our health system on any of the technologies we build. And the example of ChatGPT-4, like, I would not recommend anybody to go put personal information or PI, personal health information or personally identifiable information into the web version of ChatGPT. But the version of ChatGPT that we have sits on a secure cloud instance provisioned by the health system, where none of that data is going back up and being used for further training. And that was provisioned by our IT department for us.
Great, great. And I absolutely hate to wrap this up because we have a lot of great questions, but I know both Michael and David have clinical things that they have to get to at the top of the hour. So I'll just finish with one last question. Their question came in about, are you familiar with Amazon Clinic? And given their reach, how do you expect this will affect digital health? I'm curious your thoughts on that as a wrap-up question.
I know the folks at Amazon really, really well in their senior leadership. Amazon Clinic is definitely offering accessibility and convenience. They take a kind of a white labeled approach where they have partnered with a lot of the national telemedicine companies, and then they white label them to offer services. And they're really targeting kind of the Amazon Prime consumer market. So more maybe middle class to upper class patients. We're really focused, on healthcare is local. Our on-demand service line, very similar to Amazon Clinic, is provided by our local clinicians. We accept insurance, Medicaid insurance. We also have pay out of the pocket options for uninsured patients. And so, we're really, targeting a different, I think, target market. But we believe healthcare should stay local with health systems and communities. And that's the differentiator, I think, for us, for Amazon Clinic.
Fantastic. Well, thank you both so much. Really appreciate you taking the time. Thank you, everyone who joined us online. A recording of this program is going to be made available and will be sent automatically to you probably sometime in the next week. So keep an eye out for that. And I hope everyone has a great afternoon. Thank you again, Michael and Dave. Really appreciate your time. This was fascinating. Take care.